Hello and welcome to the Manual Therapy versus Frozen Shoulder online course. Whether you are a manual therapist, perform manual therapy, want to know how manual therapy might help with frozen shoulder, or just want to learn some of the latest evidence and management strategies for frozen shoulder, then this is the course for you. The course was designed with you, the manual therapist, in mind, designed to inform you in a way that will support the best assessment and management strategies for your patients. A way that includes helpful manual therapy techniques that can be used with real people in your everyday practice. The course will endeavour to answer the following questions for both yourself and your patient. What do they have? Where does it come from? How long might it last? What can you or they do about it? And what are the consequences of this condition? So enjoy the course. Let's get started with answering those questions. In this video, we're going to have a look at assessment, and this is how you can assess for frozen shoulder. The clinical definition of frozen shoulder is this: loss of glenohumeral range of motion by 25% or more in at least 2 movement planes. There should be at least a 50% loss in the direction of external rotation compared to the non-affected side, and there'll be a history of pain and stiffness of 1 month or more, with the symptoms being either stable or increasing. You may also wish to look and ask about risk factors. Frozen shoulder is more common in the age range between 40 and 50 plus, and is often referred to as the 50-year-old shoulder. It's also more common in females than males. Obesity is also a risk factor for frozen shoulder, and obesity has been linked to increased inflammatory markers in the bloodstream, again a risk factor for frozen shoulder. Frozen shoulder is also 5 times more common in the diabetic population. Here's some assessment tips for you. Check what's moving. Is it the glenohumeral joint working in combination with the scapulothoracic motion, like so? Good. And again, so lots of glenohumeral joint motion and the scapula's also rotating. Or are they shrugging the shoulder up as a compensation in order to help lift the arm? And this is called the shrug sign. It's due to stiffness and lack of mobility in the glenohumeral joint, and a simple compensation by the scapulothoracic joint being hitched up with a shrug motion in order to lift the arm. And then we're looking to see if the motion is restricted both actively and passively. So if a patient is struggling to lift their arm into forward flexion, for example, with a true frozen shoulder, their limitation of active motion would be the same as, or very near to the same as, their restriction passively. So if you came in and tried to move it passively or added in the overpressure, there would not be any further movement available. It probably would not be frozen shoulder if their active motion was at one limit, but you were able to considerably move them on further passively. That would not be an indication of frozen shoulder. So again, we can look at that in different directions. We can look at the active abduction, which for a frozen shoulder would be much the same. But if it was something different, like a shoulder pain syndrome, maybe a tendon irritation, for example, then passively you should be able to take the shoulder a little bit further. And finally, don't forget, external rotation is an important one to look at when you're assessing for frozen shoulder, as it's often one of the most restricted movements. And that again would be restricted both actively and passively in comparison to the other side. This condition is often overdiagnosed, and one reason for this is that in practice it can be difficult to differentiate between joint stiffness and muscle guarding. The clinical features to look out for during your assessment include the following. The pain is typically reported to be diffuse around the glenohumeral joint, and often the deltoid tuberosity is a site of specific pain. loss of overall range, with both active being as limited as passive range. So there's no or minimal extra range available with overpressure. Next, you may wish to ask, to what extent do you think pain guarding may be contributing to the restriction? At this point, I'd like to introduce you to a technique known as manipulation under anaesthesia. It's probably not an option for you and for many of your patients, and I'm not showing you this next video as a treatment recommendation. It is instead to get us thinking about the complexity of the condition, the pathology and the pain. So have a look at these next video clips. They show frozen shoulder manipulation under anaesthetic. To clarify what you've just seen, some patients with frozen shoulder, that is a physical restriction, don't have frozen shoulder when you sedate them, or the movement is greatly improved. So this raises many questions. Does this mean that it's all pain guarding for these patients? Is it for them perhaps a brain problem and not a structural glenohumeral joint problem? Have these patients been incorrectly diagnosed? Possibly. But unfortunately, we cannot answer these questions with any conviction. But we should keep these questions in mind during our assessment and management. We should also consider if any ongoing medico-legal cases are interfering with our patient's recovery, because it's very common for ongoing medico-legal issues to cause a delay and to disrupt the recovery from musculoskeletal conditions. We see that a lot with neck pain and whiplash. We see it with shoulder pain and with other spinal pains as well. So moving on, to what extent is pain guarding a feature? Is the patient sufficiently informed and educated about their frozen shoulder condition? How certain are we at this stage of our diagnosis? So we've done some diagnosis so far. Now we can have a look at other possible causes of shoulder stiffness. One big one, of course, is post-operative stiffness. After operations such as a mastectomy, for example, it is common for the shoulder to be stiff, and this would not be frozen shoulder and would likely just be stiffness from the trauma of surgery and scar tissue. Another big one is osteoarthritis, and this can often be misdiagnosed as a frozen shoulder. We'll look at how to detect that in just a moment. It may just be excruciating shoulder pain, which is significantly limiting movement, and this might be caused by an acute tendinopathy. There may have been a recent dislocation, and the shoulder might be in a state of protective spasm. There may be significant fear of pain from movement. A more serious cause of ongoing shoulder pain might be avascular necrosis or a tumour. Shoulder pain can also be referred from the heart, lungs, stomach and pelvis. So if the patient's had any procedures to those organs, that might be the cause of their shoulder pain. Next, let's consider X-rays and blood tests. One of the ways in which you can improve your care of the frozen shoulder patient is to see frozen shoulder as a potential symptom of a more general health problem. We need to consider general health and lifestyle as core components of our assessment and treatment, and not just holistic additions. In many cases, it may be a mistake to only see it as a glenohumeral joint problem, and it's a good idea to encourage the patient to get some general health tests from their medical doctor, and in some countries, like here in the UK, an X-ray is recommended in the official guidelines if there's a suspicion of frozen shoulder. So to be clear, the reason you would request an X-ray is to rule out osteoarthritis, avascular necrosis or tumours. We can tell the patient that the X-ray will not diagnose a frozen shoulder, only help to clarify it and eliminate any other causes. What about requesting blood tests? Well, unless you're a medical doctor or you have specific healthcare guidelines in your region, then it may be more difficult to organise a blood test, and you may need a better reason than just frozen shoulder in isolation. So what I would recommend is that if the patient reports or displays any other signs or symptoms of poor health, then make a note of these and suggest that they visit the doctor. You can always write to the doctor yourself for peace of mind, knowing that you've relayed the information to them. So following your subjective and objective assessment and possibly getting some extra tests like the x-rays and blood tests, you may now be in a position to suggest that frozen shoulder is the most likely diagnosis. Frozen shoulder was originally labelled in 1934. Since then, it's been renamed a few times. Adhesive capsulitis, shoulder contracture syndrome, but it's generally referred to now as frozen shoulder. So we're back to where we started. So in this video, we're going to consider where frozen shoulder might come from. Research has identified a likely inflammatory component to frozen shoulder. And it's important to consider this because it tells us that frozen shoulder may not be a simple shoulder problem, and it may be a joint issue that's caused by another illness or a problem with the patient's general health. On this next slide, you can see a potential list of causes, but as you can see, of the many causes, some of course may remain unknown. If we want to look further into the potential causes of frozen shoulder, this study here shown on the screen provides some fascinating insights into the potential causes of this common and problematic pathology. Here's some key points from the study. There is identified contracture of the glenohumeral joint capsule. There's also identified chronic synovial inflammation and raised levels of inflammatory cytokines. There's also identified significant angiogenesis of the joint capsule, which is seen on imaging. Frozen shoulder and Dupuytren's share a similar fibrotic type pathology that's associated with fibrosis. And frozen shoulder may be linked to poor metabolism of adipose tissue. The strong correlation with diabetes indicates the need to investigate improved diabetes management as a strategy for tackling frozen shoulder or reducing its prevalence in the patient group. So these were some of the key points mentioned in the review. At the time of writing this course, the full review article was available free online and it is a recommended read. When we get asked the inevitable question, how long is my frozen shoulder going to last? We want to say a few weeks. The patient wants to hear a few days, but what happens when we say a few years? In reality, frozen shoulder is reported to last between 1 to 3 years. This is a broad time frame, of course, and even 1 year is not positive news. But the truth is that if we don't tell the patient the evidence-based truth, then we're setting them up for disappointment and a reduced confidence in healthcare providers. So we need evidence-based, realistic expectation, even if it's not what the patient wants to hear. Let's look at a role play of how this might play out with a patient. Hello Rose, how are you today?
Okay, thank you. I've been doing a bit more with my shoulder, but it's still a bit painful.
Okay, let's have a look at your notes here. So we had your x-ray results back, and positively they showed that the glenohumeral joint, your main shoulder joint here, was normal, and they also reported that there were some slight changes in the AC joint, the smaller joint up here, which really doesn't have anything to do with the potential shoulder issue that you have. And I just wanted to report that because it does say that on your notes, but also to let you know that that's quite common and really seemingly quite normal. So the x-ray was positive, didn't show any issues with the glenohumeral joint, the main shoulder joint, and was overall rather a normal x-ray. So moving forward from there, based on your movement tests and the information that you've shared with me over subsequent sessions, it's most likely that you have frozen shoulder. Now, do you know much about frozen shoulder?
No, only that it can last a long time.
Yes, it is a condition that you need to manage rather than try and cure or look for any quick fixes. But the good news is that it does usually improve on its own, although it's important that you do the right things so that your function is restored as much as possible.
Great, so it will fully recover?
Well, based on my patient's typical experience and the experience of many documented cases, it is likely to have a lasting effect perhaps on your full range of motion, but this seems to be reduced significantly for patients who keep active during this condition.
So is this it then for like a year, 2 or 3 maybe?
Well, no, absolutely not. Firstly, frozen shoulder seems to go through stages. The first is the painful stage where you can move it, but you avoid moving it because it hurts, typically a lot. Secondly, it becomes much stiffer and it's not really possible for you to move it, and it then presents as a much more physical restriction rather than just pain. And then in the third stage, it starts to recover and people say feel like it's releasing, albeit it can still be painful to get the shoulder moving again.
So this is stage 1 for me?
Most likely, yes. There is debate about whether the stages actually exist, how long they last, or indeed if they occur in every patient. But it's generally agreed that frozen shoulder goes through this loose 3-stage process. So Rose, let's have a look at what we can do to help you at this stage.
Brilliant.
Here's a few extra tips when talking things through with patients. Try not to say that it's self-limiting, as this may lead to the patient doing nothing in terms of movement and rehabilitation, which is in itself self-limiting. Frozen shoulder is usually in the non-dominant arm. If you've had frozen shoulder in one arm, there is an increased risk of getting it in the other arm, but it's very rare to get it in the same arm twice. Overall, keep your diagnosis open so that you can reassess or refer to the GP if any new symptoms arise. Before we get our hands on, let's look at some of the options that may be available to your patient. We should make them aware of these so they can ask their medical doctor for more information and a potential referral. My advice is do not tell the patient they need any of these or communicate to the medical doctor that they need them. Just simply suggest that they discuss the options with their doctor. Aside from an X-ray, which would justifiably be a more assertive request and likely based on local healthcare protocols. So one of the medical options that exists is to inject the capsule with corticosteroid and an analgesic, and this is often combined with guided physical therapy for a short time period afterwards. It may also be possible to get a surgical release of the capsule or to pump up the capsule, which is called an arthrographic distension. We've already discussed blood tests, and these might be suggested to help look for raised levels of inflammatory markers. We've discussed X-rays, but MRI scans may also be considered. And we also touched upon diabetes and how its management may help with the management of frozen shoulder. When we consider well-being, first off, there seems to be links between chronic systemic inflammation and many of the other things that are associated with frozen shoulder. So things to look out for or to listen for when you're talking to your patients are poor sleep, low mood, poor diet, low activity levels, and any mention or signs of persistent or chronic pain in addition to the shoulder problem that they're presenting with, and any other health issues as well. Because there's reasonable and scientific justification to suggest that your patient's overall physical and mental health, and this includes their lifestyle of course, might be contributing to their problem. It's really important to recognise this before beginning any more targeted manual therapy. To help your patient improve their lifestyle, it may be worth learning about motivational interviewing strategies. This course includes a short video introducing you to the key principles of motivational interviewing. Hang on guys, we're almost there, almost ready to get hands-on and get practical. Before we begin any pushing, pulling, poking, shaking and taping, we need to prepare the patient to expect a realistic outcome from our input. So we need to be clear, we're not fixing their shoulder. We cannot take the pain away. We can help to treat the issue, but in a limited way. and we need the patient's input and involvement even with passive treatments. It's important to include some form of pain education into our treatment sessions as well. So again, you'll see a video on how to explain pain to patients as part of this course syllabus. It's then important to have some goals and outcome measures. For example, the patient may wish to return to work, restart a hobby, regain some form of independence that they lost due to their shoulder pain. And these may be measured by their ability to do specific tasks, such as lift items onto a high shelf, turn a steering wheel, swing a racket, or dress independently, for example. And these specific tasks may require an increased range of motion, such as elevation, internal rotation, forward flexion, and external rotation. So we can measure 1 to 3 movements. We could measure active range of motion using a goniometer or an app on the phone. We can measure power using a biofeedback cuff, or I like to sometimes use a suitcase weight measurer as it's a simple and inexpensive thing to use. We can also ask for a subjective measure of their confidence during the movement, rating it perhaps from 0 to 10, with 10 being completely confident and 0 being unwilling to try the movement in the first place. So for our patient, R3 will be supine elevation, external rotation, and the shoulder press action. We're going to test active range of motion, power at end of range, and the confidence score between 0 and 10. When you're working with shoulder pain, it's also a good idea, if you have time, to include a shoulder pain questionnaire, such as the one shown on the screen here. So here we have arrived finally at the doing part of the course. Here we can start by considering the fact that thoracic, cervical and scapular mobilizations may alleviate joint and muscle sensitivity and stiffness caused by compensatory movement patterns and hypertonic pain guarding. It may also offer a general hypoalgesic response, as massage and mobilization so often do. Here we'll look at some simple measurements for the supine elevation. So the patient has their arms straight, take the arm up, they're lying on their back flat with their knees up. Just make sure you replicate that when you retest the next time. You can take a standard cheap goniometer and use that to take a measurement. The other thing I'll do is measure their strength, and I need to take a point in the range to measure the strength. So to be consistent, I'll measure their strength at end of range or near end of range. To do this, I'm going to take an inexpensive piece of testing equipment, which is actually, as I mentioned earlier, a suitcase weighing device. So there you go, you can easily purchase those online or in a shop in town for an inexpensive price. So you can see that was an easy way of taking a measurement. Now, of course, more expensive measuring equipment is available, but I would ask whether it's necessary. If you have it, fantastic. If you don't, it's probably not going to influence your treatments or your assessments that much. And also, some people like to use their phones to measure joint angles, which is fantastic, but I'm always worried that I'm going to get a phone call or a message come through as I'm using that with the patient. But if you have an app on your phone that measures joint angles, then brilliant. Definitely you can use that when measuring the range of motion of the shoulder. What you're looking for ultimately is a benchmark that you can then return to and use for remeasurement, hopefully to monitor progress as the patient works with you into the future. From this same position, you can measure external rotation. Have the patient with their elbow in by their side and ask them to externally rotate the arm as far as they can. Of course, with frozen shoulder, this is usually a very limited movement. And then you can take one of your measuring tools and use that to get a measurement of external rotation. You can also measure strength at end of range. The next movement that we can measure is the shoulder press. So decide where you're going to take your measurement. I'll use the spine and the upper arm. So using the goniometer in line with the spine and then in line with the arm. I'll measure to see what the maximum range of motion is that the patient can achieve. So if I put the goniometer on the front there so you can see it a little easier, it'll be around here on the back there, in line with the spine, in line with the upper arm, to take a simple measurement. We can also use our simple device to get a reading on strength at end of range. So if this was the patient's limit, go ahead and get them to push up into the shoulder press as hard as they can and take a reading using the simple suitcase weighing device. With all three of those tests, don't forget to also add in your confidence score, which of course is a much more subjective score, but you want to ask the patient how confident do they feel performing the supine elevation, performing the external rotation, and how confident do they feel pushing up into a shoulder press action. Those figures are important, and I've consciously steered away from asking about pain because we're trying to take the focus away from pain and put it more into function and confidence in movement. So a confidence score is a conscious question to ask rather than just defaulting to asking them how much it hurts. In this video, we're going to have a look at some passive manual therapy treatments for the cervical spine. And the reason we're doing this is because it's often common to get compensatory muscle action and tension up around this region, around the upper trapezius, for example. And that's because of the shrug sign that we looked at earlier, where the patient is unable to move the glenohumeral joint much, or it's very restricted, and therefore they shrug their shoulder in order to get some kind of compensatory abduction through the arm, thus creating tension and overuse and muscle tension in this region. So we're going to have a look at addressing that with some passive treatments. And this can be achieved with manual therapy up over the upper traps and lateral side of the neck. So using here one of the rock blades tools to do some IASTM, and I like to use these because they've got the smooth beveled edge, which allows me to start up in the hairline, dropping off into that suboccipital space, and then flowing down over the mass of the upper traps, and then migrating out towards the shoulder, keeping the tool posterior to avoid hitting the AC joint, and then coming round over the posterior deltoid. Typically this tool can be used without the need for any wax or emollient, but it's really no problem if you need to pop some on in order to get the tool gliding over the skin. This is usually well received by the patients as well, as the smooth beveled edge of the tool glides nicely over the skin and is a very comfortable experience. When I'm performing this, I look out for the skin reaction, and if the skin starts to redden up and look erythemic, that usually means it's time to stop and move on to a different technique before we get any skin irritation. You may also notice I'm supporting the head because heads are heavy, they weigh about 4.5 kilograms. So I'm providing a headrest with my hand there so the patient can relax in that position. In addition to the tool, I like to use the back of my hand where I can work down over the upper traps with a simple hands-on technique. Treatment in the prone position is also perfectly possible, and again it just depends on your preference or your patient's preference. So we can work around here like so. I find the prone position is probably the most passive of positions to treat around this area because the patient's in a somewhat fixed position. In supine you can move their neck around, and obviously in the seated position you can be much more dynamic, but it's good to have options or to treat in these different positions when you're working with patients. These passive soft tissue techniques can also be performed with a patient in different positions, such as lying down in supine like so. So again, I'm going to use the back of my hand to start up on the back of the head there in that suboccipital region, and then slowly move down over the upper traps where I can move out laterally towards the shoulder, or come down a little bit more posterior, and I'm supporting the weight of the patient's head, which I can also use to my advantage by side flexing away as I go through with the soft tissue treatment as well. So we've got a bit of passive range of motion moving into a light stretch in addition to the massage treatment. The tool can also be used in this position. Once again, gliding down over the skin like so. This position, sometimes the couch can get in the way a little bit when using the tool, so you may need to hold it at a different angle. And I prefer to use the tool with the patient in a seated position for that reason. But if you prefer to treat in supine, then you can easily adapt your technique whilst the patient is in this different treatment position. From this supine position, we can also do some assisted stretching techniques. So if I take Rose over to the left, I'll naturally be creating a stretch through the right side of the neck here. And once I reach a point of light stretch, I can ask Rose to push her head lightly into my hand. So she's trying to return her head back to the neutral position, moving it towards you. And after a few seconds, or say 5 or 6 seconds, Rose can relax. And as she relaxes, the stretch reflex is a little bit dampened by that contraction, which means we should then be able to side flex a little bit further before we reach that point of stretch again. And we can then get Rose to push her head into my hand, pulling her head over towards you, but I'm blocking the movement, so it's a static isometric contraction. And then relax, and we can move a little bit further into that position. We're doing here quite a pure side flexion. We can also investigate with a little bit of rotation and just change the tension on the neck musculature. We can also change into a little bit of rotation so we can move the stress onto some of the different muscle fibers in the neck and side flex across. So a little bit of experimentation as to whether it's pure side flexion or side flexion with a bit of rotation or with a bit of flexion. Side flexion with extension is sometimes a little bit uncomfortable, so usually having a little bit of flexion is more of a preferred option. But the basics are side flexion up to the point of stretch. Patient applies some resistance to try and return the head back towards neutral. You block that movement, so it's a static contraction. Hold that for 5 or 6 seconds. Then they relax, and when they do, the dampening of the stretch reflex allows you to move across a little bit further. And this can certainly help if there's tension in the upper traps there due to that shoulder shrug compensation that we looked at the very beginning. Combining that with the massage techniques is highly recommended. Next, if you are comfortable with handling and moving the neck, then you can also look to do some neck mobilizations. And these target the joints a bit more rather than the muscle. Using one hand to cradle and hold the head securely to take the weight of the head, use the side of the index finger there to create a pivot point or fulcrum on the mid part of the neck. And then all you need to do is gently bend the neck over the side of your finger there in order to create a side flexion mobilization. Okay? Now this is not a manipulation. If the patient has a particularly stiff neck, you may get some clicks or cracks from the neck, which are cavitations, but the movement you're doing is a gentle movement within range. You're not going to be pushing the patient into a range of motion which they don't want to go into or their neck is not naturally moving into. It's just very natural movement as you side flex the neck. Okay, this should be a gentle movement. Again, try to get your body involved rather than just making it all from your arms. So with a wide stance, just allows you to move more fluidly as you side flex the patient's neck. Okay. Now, most of you are probably using mechanical massage devices such as massage guns, etc. I've got here one from Rock Tape, which is a mechanical massage device, a little bit different than a massage gun because the end oscillates around laterally rather than moving in and out vertically. So people report that it provides a bit more of a gentle massage in comparison to a more traditional massage gun. Anyway, we can use this over the upper back and neck region, and it can be used easily over clothing. And it can provide a quick and simple massage with some benefits for the patient in that they can experience some pain relief and reduced muscle tension. A couple of tips for using these. Firstly, don't apply much pressure. Just use them lightly over the skin or over the clothing. In fact, using them over clothing might be recommended because the clothing provides an extra level of dampening to the mechanical force, which can just make it a more therapeutic experience for the patient. Another tip is don't use them for too long. Over any given area, 10 to 20 seconds is usually plenty of time. So it's maximum of a minute, I suppose, over a larger region would be absolutely fine. There's no need to sit there for minutes, 5, 10 minutes or beyond. You're likely to start to get some irritation if you're using them for an extended period of time. So light pressure, over clothing perhaps, and only use them for short periods of time and then move on to something else. But most patients will find them helpful, and most of you have something like this in your clinic, so don't be afraid to use them for general soft tissue work when you're dealing with some of the side effects of frozen shoulder. For this next technique, we're going to have a look at some cupping techniques to reduce any unnecessary muscle tension around the upper traps. So I've got here some silicone cups, some rock pods, and I've put a little bit of wax around the rim of each one just to help them get a good seal as we place them over the top of Rose's shoulder here. So I put 1, 2, and hopefully enough space for number 3, like so. And then I'm going to instruct Rose to stretch away from the pods, stretching that lateral side of her neck there. And what Rose can expect to feel here is an enhanced stretch as the vacuum from the cups is creating some shearing underneath the skin in combination with Rose's active movement, which is pulling the skin and underlying soft tissue away from the cups to create this feeling of an enhanced stretch. So this is an active cupping technique, very different than traditional cupping, but it's one which I found has been very effective for reducing tension up around this region. Next, let's have a look at what else we can do using the vacuum from the cups in order to create a very therapeutic gliding effect down over this area. This next technique is glide cupping. I've got a special silicone rock pod here which is designed for glide cupping, and I've made sure that there's plenty of wax over this area because I'm going to need that to help the cup glide over the upper shoulder. I'm going to start here just at the base of the neck, and I've put the cup on with a little bit of vacuum, not too much, because it's, less vacuum makes it easier for the pod to glide. Okay, holding on, I'm going to gently glide down over the shoulder, and then I should be able to bring that back again up towards the base of the neck. And if the vacuum releases, no problem, just pop it back on again and glide back down. As we did with the active cupping, I can start at the base of the neck and then instruct Rose to side flex away as I glide down over the shoulder. Okay, and I'm going to remove that there, start again at the top, and Rose moves away as we glide down over the shoulder. It's typical to do about 3 or 4 of these, after which the skin can get a little bit red from the cup gliding over the skin. So 3 or 4 is usually enough for this therapeutic intervention. All right, let's see what's coming up next. In this video, we're going to have a look at some soft tissue techniques below the shoulder and around the thoracic spine and scapula. So in the side lying position here, you can abduct the patient's arm as far as is comfortable, and of course, often with a frozen shoulder, you won't be abducting it very far. And then you can start to work around the back of the axilla, over the teres minor, teres major, and then broadening out your treatment and working down over the lats in order to try and reduce muscle tension and sensitivity, and maybe get a bit more range of motion out into abduction. So there's various techniques you can use. You've probably got many of your own, using different parts of your hand or even using your forearm to come down over the back of the arm and down over the lats. I also like to use some tools. Here I've got one of the rock pods, which is great for grabbing a hold of the soft tissue, and then you can do some active release or pin and stretch style techniques as well. These rock pods, these cups, are great soft tissue handles, so you can pop them on and mobilize the soft tissue and the underlying contractile tissue. Absolutely fantastic, easy to use, and often well appreciated by the patients as well. If you've got enough wax and emollient on, you can also get these particular tools, these are the rock pod glides, to glide across the skin, and that can give a really nice massage effect as well. You've seen in the earlier videos, I also used a massage tool. Here I've got one of the rock blades, and I like to use this as well because the smooth beveled edge easily glides over the patient's skin, and you can glide it down over that fascial line there, right down towards the thoracolumbar fascia. So that can work really nicely. Top tip, just make sure that these are warmed up and aren't cold when you first take them off your treatment table and start to use them, as the patients might get a little bit of a cold shock if you don't do that. So that's the first treatment approach, down over the back of the armpit and down over the lats towards the thoracolumbar fascia to take care of that line of fascial tissue. In the prone position, you can target your treatments over the thoracic erector spinae and around the scapulothoracic muscles as well. While the patient's in the prone position, you can also do some gentle pressing down over the thoracic spine. These certainly aren't manipulations because you're just simply applying some gentle, tolerable pressure down through the spine, pressing down slowly and releasing slowly. That's over the center of the spine. You can also do that over the rib angles. You may get a few clicks and clunks, but you're not doing any high velocity thrusts, so you're not doing any manipulation techniques. When you're doing your soft tissue techniques, it's also an idea to do some soft tissue work over the pecs. So with the patient lying down on their back, bringing the arm out to their side in a comfortable position, you can then do some massage techniques over the front of the chest, like so. This is one of my favorite scapular mobilization techniques. Use one hand to grab around the medial border of the scapula and the other hand to place over the top of the shoulder, so that you can also push the shoulder back, which will help to lift the scapula away from the rib cage. And then what you can do is mobilize the scapula in different directions. I like to mobilize in broad circles like so. It's also great to just simply pull the scapula away from the center of the spine and to get some stretching through those rhomboids there. In addition, you can stretch away and then start to abduct the arm, and that can really help if the scapula's feeling a little bit stuck over the rib cage. So circles, big circles up to the level of tissue resistance, pulling the scapula directly away from the center of the spine, and also getting some abduction of the arm going on and rotation of the scapula. Those three key movements repeated over the course of a few minutes of therapy can make a significant difference to the patient's feeling of mobility and range of motion around the arm. In these next clips, we're going to look at some techniques for mobilizing the thoracic spine. So for this first one, we'll get the patient to put their hands behind their head and encourage them to flex forwards, dropping their head down and getting as much curvature through the thoracic spine as possible. Then coming back up into extension, bring that head back, sticking the chest out and getting as much extension through the thoracic spine as they can, and back down again, and repeating that 3 or 4 times or more if it feels particularly good when they're doing the exercise. Then back to neutral, taking the arms down. Rotation, so rotating one way, rotating the other way, and if they exhale at the end of movement, they might get a bit of extra rotation as they go round. This is also a great exercise known as thread the needle. It's fantastic for thoracic rotation. Pushing the arm through the space between the arm and the leg, hence thread the needle, and rotating as far as possible, going in both directions. And you can also encourage the patient when they do the exercise to drop their shoulder down to the floor or down to the couch in this case. Even if they can't do this with much range, it's still great if they can have a go and get some rotation through their spine. Next, we can do thoracic extension over a roller, a classic exercise. Now, the colour of the roller, of course, doesn't matter, but a few things may matter, in particular the size of the roller. So I'm going to use here a smaller roller and have a look at doing the exercise. Having a roller that's comfortable rather than a big spiky one absolutely makes sense. So take something that's suitable for the patient so they can use as a pivot point, as a fulcrum to get some extension through the thoracic spine. So let's have a look. We've got the smaller roller here, a cushion behind their head so they don't have to extend too far, and we'll now have a go at doing the stretch or the mobilization. So the roller usually goes in the mid to upper thoracic spine, and usually we get our patients to put their hands behind their head. However, if you're dealing with somebody with frozen shoulder, that might not be possible. If one shoulder is too tight or painful, simply place that across the chest and have one hand behind the head whilst they go into that extension position. Placing a suitable amount of pillows behind their head so that you can achieve just the right amount of thoracic extension. Just enough so they feel it, but not enough so that it causes them discomfort or discourages them from doing the exercise in the first place. So those were simple mobilization techniques that the patients can either do themselves or with a little bit of guidance from you. Now, if you're trained in spinal mobilization and spinal manipulation techniques, then there's probably some great techniques that you can add to that in order to help the patients with their thoracic mobility. Because frozen shoulder affects the glenohumeral joint, it makes sense to target that joint with our manual therapy and our exercises. However, you must remember that there's an active pathology going on here, and the glenohumeral joint may not take kindly to some of our enthusiastic, well-meaning manual therapy efforts. That doesn't mean we shouldn't try, it just means we need to approach it in the right way. So let's have a think about how we can do that. With the patient's consent, try some of the following techniques that I'm showing on the screen here. Explain to the patient that it may cause an increase in pain during and after the treatment, and that in the early phases of frozen shoulder, these types of treatment approach should be avoided. However, in the latter recovery stages, it may help just as long as it does not make it worse. The only way you can really find out is to try it. But the patient needs to know that these treatment approaches are somewhat experimental, and you need to explain to them that you are trialing them rather than them being a guaranteed fix for their shoulder. Setting up this correct and balanced expectation is the best way to approach the utilization of these treatment approaches. In this video, we're going to look at 4 of my favorite tried and tested and preferred exercises for a stiff shoulder. So brilliant for rehabilitating from a frozen shoulder. The first exercise is the classic child's pose balasana yoga stretch, where the patient can begin to drop their bum down towards their heels in order to stretch through the shoulder and try and improve the elevation. Of course, they won't be able to drop right back if they've got a stiff shoulder, but that's something that they can work towards as they progress through their rehabilitation. Once again, a roller can be a handy thing to use, so they can place one hand on top of the roller, which will put a bit more stretch through the shoulder as they drop down. And then they can also use the roller to roll away and encourage a little bit of extra opening up of that shoulder forward flexion movement. With all of these stretches in this child's pose position, rotation of the arm out into external rotation, so turning onto the side of the hand would help to externally rotate the arm, will slightly change the way the shoulder experiences that stretch, slightly change the muscles and the fascial fibers that are being loaded as you go into the end of range. So it should be encouraged that the patient begins to externally rotate their arm as they move into that stretch position. So holding that external rotation on the side of the hand there and stretching forward. That's a good little thing to add in once the patient's got to grips with the basics. Next, we're going to have a look at eccentrics into elevation. So encourage the patient to hold onto a weight. We're just going to use a roller here to get to grips with the movement first, and then get them to elevate as far as they can, under control, so without you helping. I'll take my hands away now. As far as they can, hold that end position, contract the muscles in their shoulder at the end of range, count to 3 or 4 seconds, and then bring the arms back again. They don't need to go all the way back. They want to focus ideally on that final 10 to 20% range that they have available. Contracting the muscles at the end of range and then returning back into a comfortable range before going back towards the end of their available range again. So we've switched out the roller now for some weight, which means we can work on an eccentric lengthening into the end of range. It's really important the patient controls the lowering of their arms towards the floor, using the weight to add the resistance, and that eccentric lengthening is what we're looking for with this exercise. Of course, you don't want the patient to drop the weight onto their head. Of course, they wouldn't do that, but just bear some thought to how well they've got the weight and how well they're gripping it, and also that they understand the exercise. So with a patient who's not particularly competent with weights and with exercises like this, get them started with something softer like the roller to begin with, and then if appropriate, give them a weight so they've got some more resistance that they can work with into end of range. Standard exercise principles apply here, so you're probably going to be doing somewhere in the region of 3 to 5 sets once the patient's got some competency, and using, to be honest, just a light to moderate weight. There's no need to go really heavy with this unless you've got somebody who's very competent and used to using weights. A light to moderate weight is probably going to be perfectly sufficient in order to get this to work. I've had some great results with this in clinic, great feedback from my YouTube videos as well. It's not always that easy or that comfortable, but it does tend to give the best results out of all the exercises that I'm showing you here. And I think that's because it's combining stretching with loading. So it's combining the stretching with the strength and conditioning elements as well. For this next exercise, we're working on external rotation. So the patient can internally rotate, that's usually quite easy and not a problem. And then they need to focus on controlling the resistance as they move their arm out into external rotation. Once again, focusing on the end of range, the end of range zone, so that last 10 to 20%. So they could be working from here, as an example, out to here, and really working on controlling that external rotation, trying to increase it, but working on the strength in their outer available range. Another top tip, which I have not yet mentioned, is that if you grip your fist, it actually increases the activation of the rotator cuff muscles as well. So with all of the exercises, making a fist and gripping, so squeezing the exercise band, the resistance band there, can actually increase the activation of the rotator cuff muscles, and that might be advantageous. It might help you move further or with less pain. This is a classic home exercise to teach your patients that have a stiff shoulder. Very easy to do. Place the hand on the wall, assuming this is the stiff shoulder. Use their fingers to crawl up the wall. This is known as the wall crawl exercise. Then place the hand against the wall, keeping the arm fairly straight, and then bending the knees, bending at the hips, and starting to squat down in order to increase the elevation through the shoulder. And back up again. They may not be able to go too far, but the idea is that the fingers crawling up the wall, followed by bending the knees, bending the hips, dropping the body down, will help to increase the forward flexion through the shoulder. This exercise can be done with both hands on the wall if the patient prefers that. And also don't forget that the hand position or the rotation of the arm can also make a difference. So try and encourage patients when you can to externally rotate through their arms, as this can slightly change the stretch stimulus over the shoulder. And of course, external rotation is the other key movement that we're looking to rehabilitate. Elevation, whether it's out to the side or forward, and external rotation. If we can restore those two movements, that usually massively increases function for patients with a stiff shoulder. Regarding the exercises and whether to do them in the presence of pain, it is generally agreed that it is acceptable to do the exercises even when there is some discomfort present, as long as that is okay with the patient and that the pain levels are reported as being relatively low, so below 3 or 3 maximum, for example. All of that's debatable, but the key message is it's okay to do the exercises in the presence of some discomfort. However, the discomfort or any discomfort that occurs from doing the exercises should decrease after 12 to 24 hours. If it does not and it lasts longer, then it's an indication that the exercises may have been too vigorous or implemented too soon, and therefore they should be reduced in their intensity or reduced in their frequency. So post-exercise soreness has some acceptability, but it depends on how long it lasts as to whether or not that should cause you to reduce the exercises or even put them on pause for that moment. Now, before we finish, I just wanted to show you another exercise that's fun but helpful. I'm using here a laser. These are inexpensive and easy to get hold of. If you look them up online, they're often advertised as cat chaser toys because you use the laser pen and the cat chases it. Works for dogs too. But you can use it with your patients to help with the rehabilitation, to give them something else to focus on other than boring movements or the feeling of pain. You can use the laser where they've got to use the laser to see how far up the wall they can go, to see whether they can track patterns on the wall or write their name on the wall, for example. Giving the mind something else to focus on other than just pain and discomfort can be really helpful and a kind of distraction tactic and part of an exposure therapy, if you like. So using a laser just to create some fun movement tasks is something that I would recommend and is well received by my patients. And many of them actually go and buy a small laser pen so they can have a go at doing these things themselves at home.